an ad to come out to this women's oncology program. And I'm looking down through the program, and it's breast cancer, and it's ovarian cancer, and it's cervical cancer, and it's skin cancer, and it's thyroid cancer. But nowhere on the list is there a speaker for lung cancer. And lung cancer, as we know, is the #1 cancer killer of women. So, I mean, the reason we're sitting here tonight in some weird indirect way is because this irritated me about 20 years ago. And we actually started an organization called Women in Lung Cancer. And that ended up morphing into another advocacy group. And we kind of spun off from there. But there are a lot of disparities when it comes to lung cancer. One question that I was going to ask Dr. Ray is, I mean, do you think if these patients had breast cancer, would they be more likely to see an oncologist or something else? I mean, there is a lot of nihilism around lung cancer, and there's a lot of miseducation. I mean, I still hear, oh, they got lung cancer, you know, Jim Beam and a fishing pole, basically. You know, there's nothing you can do for them, you know. And all of that has changed so dramatically, even in the past 5 years, that there's a huge educational gap. And it's still changing rapidly. I can tell you, I feel like I'm in fight mode all the time because, you know, I order targeted therapies for our patients, and they just get declined automatically, you know. They've got an EGFR mutation. I'm asking for a targeted therapy. You know, it gets turned down by the insurance company, and it's just a fight to go back and get them. So there's a lot of issues with lung cancer, and I think part of, you know, what our group does is we help people. We bring faces to the disease, and we educate people, not just our community, but also our doctors. So lung cancer is the #1 cancer killer of women in the United States. So if you're like me and you take all these exams, you know, they'll always have what type of cancer kills the most women in the United States each year, and they'll have breast cancer as A, you know, and they'll have lung cancer as D. Don't fall for that. You know the answer. Lung cancer kills twice as many women each year than breast cancer does in the United States. Smoking is still the leading risk factor in developing lung cancer, but as we've seen and heard, non-smokers' lung cancer is a big problem. It's the 6th leading cancer killer overall, non-smokers' lung cancer. So we're bringing a voice to that, and we're trying to figure out, you know, how this can happen. But indeed, if you have lungs, you can get lung cancer. The lung cancer incidence rate for African American women is about the same as for Caucasian women, despite the fact that smoking patterns in different communities differ. And in the African American community, women tend to get lung cancer smoking fewer cigarettes than Caucasian women. And this has led to a lot of interest. Is it the type of cigarettes that people smoke? Is it menthol versus non-menthol, or filtered versus non-filtered? These are interesting observations that we've made. Radon is the 2nd leading cause of lung cancer, and this may be very important in non-smokers' lung cancer. Radon is an odorless gas that comes up from bedrock, and it basically is radiation. So we see it a lot in the Northeast. We do have granite outcrops here in the South, and so you can see it here in the South as well. But the treatment for your house, if you have a house that's got radon, is to basically aerate and mitigate the crawl space or the basement. So we know that people who have never smoked are much more likely, 20 to 30%, much more likely of developing lung cancer if they are exposed to secondhand smoke. So I know a lot of you have heard me talk about being trapped in the Cadillac with my grandmother and all her smoking sisters as a child, or if you were a taxi driver or a flight attendant or a bartender before all our smoking laws came into place. I was telling somebody I was at the Jazz Fest in New Orleans last weekend, and we're all out partying down, but we're kind of packed in pretty close, and some guy who pulls out a cigarette, and it's not smoking. Of course, it's also not drinking, but he was he was looking at that. But anyway, I got so mad. I was just like, number one, you're going to burn somebody because we were packed in there. But number two, you don't have a right to pollute my air. So anyway, there's lots of work to be done there. So the SEER data, which is a database that we use nationally to track trends in different types of cancer, has basically shown and announced that deaths from cancer are falling. And they're really falling in lung cancer, both men and women, which is very exciting. And I attribute a lot of this to education around smoking cessation. I mean, the problem is our young kids are not smoking cigarettes, but they are vaping. They are vaping like crazy. And we don't really have a lot of data as to how that affects their lungs. So probably decreasing smoking is attributed. We have better treatments, and people are living longer and are healthier in general as we age. So those are probably all contributing. But it's exciting that cancer deaths overall have declined, but specifically in lung cancer for men and women. I'll show you a little bit more of that in a second. So this is just the newest data that I could pull. Estimated number of cases overall of lung cancer, 234,000. Deaths, 154,000, and it's slightly higher in men than women, but I'm telling you, women have been catching up to the men with this disease ever since we kind of came out of, hiding our cigarettes in the cookie jar, and, we've come a long way, baby. Smoking in public, the lung cancer rates took off at that point. The overall incidence of lung cancer has decreased. I'll show you another slide that shows you that. So we're seeing decline in diagnosis for all races except Native Americans and Pacific Island women. And again, these are disparities that just need to be teased out. Diagnosis are highest in African American men and lowest in Hispanic women. And again, mortality rates have also decreased. And are decreasing for both sexes. All right, so I don't know if you hope this slide shows, but these are some of the national trends in terms of death rates. Okay, so this is liver, okay, and it's gone up by 2%. This is uterine cancer. It's gone up by almost 2%. This is brain cancer. It's gone up by 0.5%, and this is very interesting. There's a lot of discussion about, do cell phones cause brain cancer, EMF radiation, electromagnetic frequencies, and we're about to switch from 4G to 5G here, I think within the next year. Some places have already switched, but we're going to be bombarded with more radiation and EMF than ever. So it's very interesting. There's never been a study that's directly correlated cell phone use with brain tumors, but it's just very interesting. It'll be interesting to see and think about how can we protect ourselves, because we're exposed to oxidative stress in our society now more than we ever have been, with all the electronics we have and with all the pollutants in our environment. Our houses are hermetically sealed these days. There's no more drafty windows. So we're exposed to a lot more in our food and our makeup. I mean, we can go on and on and on, but we're being bombarded with oxidative stress that damages our DNA and can lead to malignancy. Pancreas cancer is up slightly. Soft tissue cancers, these are sarcomas, are up slightly. Myeloma is a wash, and then I'll just find lung cancer here. So for women, this column is women. We have dropped 2.4% decline in deaths from lung cancer. And for men, there's the lung. Let's see, oh, it's down here at the bottom. For men, it's dropped 3.8%. So again, good news for both sexes. Okay, in terms of rates of new lung cancer, again, you can see in women, this is the women column here, there's been a decline in the rate of lung cancer in women and also in men. So again, it's hard to say exactly why, but I think it's probably a combination of things. Education, fewer people are smoking, and probably better health in general. So, although the rate of new cases of lung cancer continues to decrease along with the smoking rate, lung cancer is still the second most common cancer in general and the leading cancer killer. All right, so we talked a little bit about lung cancer risk. The number one risk, of course, is cigarette smoking or secondhand smoke. And, I don't know about thirdhand smoke, but I can tell you that it irritates people's lungs. So, I have a hard time if someone has, pops on the elevator with me and they reek of cigarette smoke. I start coughing and wheezing. So I'm sure that there's, irritation to even thirdhand smoke. We talked about radon exposure. If you've had a previous cancer, for example, head and neck cancer, and sometimes even breast cancer or Hodgkin's lymphoma, or you've had radiation, again, radiation can cause cancers usually 15, 20 years down the road, either from radiation or even from chemotherapy. Certainly any kind of inflammation in the lung, so COPD often is accompanied by fibrosis and inflammation, as is pulmonary fibrosis. I don't see as many arsenic cases as I used to. I think that era is getting to the point where it's further down the road. They used to use arsenic to treat asthma. They used to use radiation to treat acne. And so they would, treat people's backs with radiation for acne. But we have plenty of things that we're exposed to. When you pump your gas, try to stand downwind and don't inhale. And of course, there's a lot of viruses. HPV has now been associated with head and neck cancer, but it's also associated with lung cancer. So if you have children, grandchildren in that 22, or I think it's 12 to 22 range, boys and girls, I'm telling you, get those HPV vaccines. It is so worth it. I have 3 of my colleagues who've had HPV head and neck cancers. Never smoked, but it's very important. And the boys are carriers of HPV, so it's very important to vaccinate both your boys and your girls. And then, of course, genetic risk. I was sitting there listening to Kim's story and thinking there must be some sort of genetic susceptibility here. A lot of times we think, well, the genetic susceptibility is that everybody smokes. But Kim obviously didn't smoke, but she probably had secondhand smoke when she was growing up. But there's more than that, and we've found some linkage studies, especially in women. But that's another area of interesting research. So these are just some little fun facts about lung cancer in women. Women seem to be more susceptible to developing smoking-related lung cancer, and that may be than men. And that may be because our lungs tend to be perhaps a little bit smaller, so the concentration of smoking-related exposure may be higher. There may be some endogenous influence that may be hormonally related. But this is an interesting. When people ask me, I frequently get people ask me at parties and things, well, how much can I smoke before I'm really at risk? It's like they want to push it to that limit and then they're going to stop. And interestingly, so I looked into this, and it's about 15 pack years for men, the risk starts to go up. Just only 8 pack years for women. So women are more susceptible to smoking-related lung cancer than men. Women are also more likely than men to develop non-smokers' lung cancer. Okay, so if you look at non-smokers' lung cancer, about 2/3, in some cases up to 70%, of non-smokers' lung cancer is seen in women. Women are much more likely to have adenocarcinoma, and adenocarcinoma tends to be that non-smokers' lung cancer. So those may be correlated there. And then despite everything, every single stage of disease, women live longer than men with lung cancer. So again, I was thinking about this in some of Dr. Ray's data, but we clearly see that women are the stronger sex. All right, you're going to have to forgive some of these slides. I couldn't figure out how to download them off the SEER database, so I just did what I could. But this is the probability of developing lung cancer by age, and this is the latest data that came out about 3 weeks ago. So this is birth to 49, 50 to 59, 60 to 69, and over 70. Okay, and so if we look at, here's lung cancer. This is men and this is women, and interestingly, these numbers correlate pretty well when they're young. So if you're a young woman under the age of 49, you have a 1 in 673 chance of developing lung cancer. And then as we age, again, with all the toxic exposures from pollution, air pollution, that number goes up. And so by the time you get to be 70, if you're a woman, it's 1 in 21 chance of developing lung cancer. This is the brand new data in terms of the estimated number of new cases and deaths. So again, new cases, women were the second highest incidence behind breast cancer. And the incidence in men were the second incidence behind prostate cancer. But when it comes to deaths, we're the leading cancer killer. And again, here you see 41 and 66,000 women dying of lung cancer versus breast cancer. And again, lung cancer sort of trumps prostate cancer also in a major way. So you can see basically, now this is interesting because these numbers have changed over the years, and I've just noticed this. But we've gotten to the point where for both women and men, lung cancer accounts for about a quarter of all cancer deaths in men and women. So this one's 23%, this is 24%. So that's very interesting because those numbers have been a little bit further apart, but they're closer together now. So 1/4 of all cancer deaths are coming from lung cancer. These are some trends in cancer mortality, and I just wanted to show you graphically. So this is men up at the top, okay? This is lung cancer. Lung cancer in men peaked in the 90s, and this is, we learned from the Surgeon General in the 70s that cigarette smoking is hazardous to your health. But people kept smoking, and this may be a little bit of lag time. So maybe people actually started to think about quitting or actually quit. Unfortunately, when I was in medical school, we were taught that if you stop smoking right now, that your chances of dying from lung cancer over about 10 years would return to that of a non-smoker. That's not accurate. Like many things that I was taught in medical school, that is not accurate information. So it does fall, and certainly your risk of heart attack, stroke, hypertension, those fall quickly. So it is always worth it to stop smoking. But you never get back to that of a non-smoker. You always are at a slightly higher risk. All right, so for women, we can see, again, it was 1987 is when lung cancer surpassed breast cancer as the leading cancer killer of women. And again, we kind of got liberated here in the 60s, and that's when we stopped hiding the fact that we were smoking, right? So that's when the lung cancer started going up in women, and then we got the message to stop smoking. Women actually did not stop smoking the way men did, and they're just now starting to stop taking it seriously. And it is interesting. I think if you talk to children these days, my kids used to embarrass the heck out of me because I would be walking along, and my daughter would say, "Oh, Mommy, he is smoking," and like it was was the most horrible thing they had ever seen. They were like, So I think our children really have kind of internalized the cigarette smoking thing, but they don't think vaping is as bad. Maybe it's not, I don't know, but they shouldn't put anything. I tell when I give educational lectures to kids, except for the freshest air that doesn't smell funny that you can find. So finally, the lung cancer rate for women is starting to dip. So this is all, these last, since 2010, this is good news in terms of lung cancer. Again, trends for mortality rates. Again, we can see here in lung cancer, here's women. So this is 1975 to 83. Death rate was 5.9%. Then through the early 90s, it went down to 3.8%. And then it dropped dramatically in the 90s to early 2000s, down to 0.5. And now we're in negative territory. So this is a wonderful trend. And we're seeing it in men too. So this is very exciting. And, I think some of our efforts are, I hope, certainly most of that is because people have stopped smoking, but maybe some of our treatments are working better. I know our treatments are working better. If I have to give a patient chemotherapy these days, I feel like I've failed them in some way. I want them to either get a targeted agent or immunotherapy, and I don't want to combine it with chemo unless I have to. Leading causes of cancer deaths by age, again, we can see here when you're under 20, the leading site is brain cancer, and then when you hit 40, it's lung cancer. All right. And this, we were talking about poverty, is the mortality rate by poverty level. So this top line for lung is male in poor countries, okay? The second line is men in affluent countries. And then when it comes to women, this is the death rate of women in poor countries. There's not quite as much difference versus affluent in death rates in women as there is in men, again, depending on the poverty level. All right, and then by ethnicity, again, we talked a little bit about these different disparities. This is a lung cancer here. These are women with lung cancer. Okay, so Caucasian women here, this is the incident, and again, it's falling. The incidence of lung cancer in African American women is slightly lower than that of Caucasian women, and again, also we're seeing a nice trend. And then here, the next one is, the next one is Asian Pacific Islander, which is the green one. And then this is Native American, which is the purple one. And then Hispanic women. We talked about how Hispanic women have the lowest incidence of lung cancer. So again, it's very interesting to me because that's quite a spread. It's really quite a spread in terms of ethnicity. All right, so the current state of non-small cell lung cancer, basically we have more choices, more decisions, because we're looking at now not histology directed, but targeted directed, genetic directed therapy, and we're looking at biomarkers, and we're looking at immunotherapy and overcoming resistance. So this is what puts me in fight mode with the insurance companies all day long, which is not a comfortable place to be. I hate that it's come to that, but that's what it is. When we're talking about targeted therapies, we need a target, and mainly those are mutations. And this is a breakdown of different drivers. EGFR this is the more, it's a sensitizing mutation. Well, there's a bunch of different ones, but sensitizing EGFR mutations are by far the most common actionable mutation. KRAS is seen more in people who have smoked, and the rest of these are seen more in people who haven't smoked. So if I have a non-smoking woman who comes in with lung cancer, I I'm gonna search for mutation until I can't breathe. If the EGFR comes back negative, I'm going to keep going down this list. ROS1, for some reason, didn't make this list, but it's down here in the 1% as well. I had a patient with a BRAF mutation come in the other day. Well, I've had two actually in the past month, and I just think, oh my gosh, if you were out and wherever, you'd be getting chemo right now instead of a pill. And the pills work better, the targeted therapies. So lots of options, more mutations are being added to our list every year. So this is the EGFR mutation. Again, it's the more common one. Again, seen 2/3 of women who are non-smokers who have EGFR mutated lung cancers. And you can see that we use these different oral agents to attack inside the cell. There are also some monoclonal antibodies against the EGFR receptor that we can use to attack on the outside the cell. Call it the above and the below approach. This is another, the second most common mutation would be ALK. This is actually not a mutation, but a gene rearrangement of this fusion protein. And again, we can target that with a pill. And downstream from that is the ROS1 rearrangement. And again, we see this more frequently in adenocarcinomas, that we also see more frequently in non-smokers and in women. So a lot of these targeted agents we're treating women with lung cancer with a lot of these targeted agents. This is just an example of what kind of dramatic responses you can get, because again, I was thinking about this with Dr. Ray. If someone comes in and they have a chest CT that looks like this, they are extremely sick. Okay, so this is the left lung, this is the right lung. This is what lungs look like when they're healthy. So this tumor has completely socked in the left lung, and when they have this really diffuse type of pattern, which is classic in all mutated lung cancers, not just ROS1, you tend to get these ground glass type appearances, but people cannot breathe. One of my patients told me, I feel like I'm breathing through cotton candy. And I can imagine that that's what it would feel like. Literally overnight. So I've had people who, we put the pill in their mouth, and the next morning they were off oxygen. It can happen that quickly. Unfortunately, a lot of hospitals now, including Mr. Newton's hospital, do not have these oral targeted therapies on formula. So it takes an act of Congress to try to get them for patients who are in the hospital. And sometimes we end up having to give them chemotherapy while they're in the hospital, and then transitioning them to targeted therapy, which is a better treatment once they get out of the hospital. But you can see what kind of dramatic results we get. I mean, almost complete, there's a little patchiness up here, but almost complete clearing of these very, very sick lungs. So these are the hallmarks of cancer, and I just put this slide up because it's such a classic slide, but it's just so exciting to me. When I first started my career, we had all these different hallmarks of cancer. We had angiogenesis and invasion and proliferation and metastasis and, resisting apoptosis, inhibiting apoptosis. And we had nothing, maybe we had chemo at one site, but we really didn't have all the options. But now we have all these treatment options to come at cancer from every different angle. So this is very exciting and very rewarding for me. When I first started taking care of lung cancer patients, there was one drug that was FDA approved, chemotherapy, cisplatin. That was it. All right, so I just want to briefly talk about lung screening, because lung screening is one of the most effective ways to get those numbers down. This is a picture of a woman going into a low-dose spiral CT of the chest. You don't need contrast. It's a quick study. In a machine like this, it'll take a fraction of a second to get the data. The goal of lung cancer screening is to increase our cure rate, to try to limit surgical resection if we do find lung cancer. The biggest one is to decrease morbidity and mortality. So those are our goals of screening. So in the National Lung Study, CT getting spiral CTs as opposed to chest x-ray decreased lung cancer mortality by 20%. And that's as good or better than many of our drugs. And there was a 6.7 reduction in all-cause mortality. Again, we looked at spiral CT versus chest x-ray in this trial, and we found that when we screen people with spiral CTs, we prevent cancer death in 1 out of every 320 patients. That's much better than mammography. Mammography, 1 out of 1,900, or even colonoscopy. So lung screening is better than mammography and colonoscopy in terms of screening for cancer. But let me tell you, family practice and internal medicine doctors are not routinely ordering these screening tests. It's part of an algorithm now, and many of our algorithms are kind of built into the system. But it's shocking to me, and again, I think this speaks to some of the nihilism around lung cancer. And there is a cost. There is a cost to this. There are a lot of false positives, and you have to get a PET scan, you have to get a biopsy, you have to follow people longer. But it's such a great test for saving lives that it's definitely worth the cost. So basically what they found was if the guidelines from the lung cancer screening study were implemented, 12,000 deaths would be averted each year from lung cancer. That's a big chunk. All right, so this is a screening CT, and you can see in 2003, this person had beautiful clear lungs. This is the heart, this is the airway, and then boom, 1 year later, there it is. And this is a classic lung mass, it's spiculated, we're called spiculated, where it's cancer of the crab. It's got these little fingers, tendrils that go out into the tissues. That is a classic looking malignancy in the chest. So in order to get screened, the screening criteria, because I thought, it's coming up Mother's Day on Sunday, what is a great thing you could do for the women in your life is to say, would you have a lung screening test if they're eligible? And encourage them to call up their doctor on Monday morning and get a lung screening test scheduled if they are eligible. So you're eligible if you're aged 55 to 80, if you've smoked for 30 pack years, so that's a pack a day for 30 years or 2 packs a day for 15 years. If you've stopped smoking, you have to have stopped smoking within the past 15 years, and you can't really have any symptoms. When we order these tests, we have to sit down and have a risk-benefit ratio discussion with the patient. A spiral CT of the chest has about the same amount of radiation exposure as a mammogram. We have to encourage people to adhere to the screening. Right now it's a yearly screening, but we'll probably be spreading that out. And really it makes sense to screen people only if they would be eligible to get treatment. If they're so sick that they could never have surgery or wouldn't qualify for any treatment, like some of the people in Dr. Ray's study, then it's probably not worth putting them through a screening test. So encourage the women in your life to get screened for Mother's Day. I think that's one of the wonderful things you can do. And again, thank you so much for coming. It's my pleasure to speak with you tonight. And together, there's always something we can do. I tell my patients this all the time. So thank you. Are there any questions? Yes.
So about the staying in fight mode thing.